I'm Dr. Bhaushital Sharma. I've been treating HIV patients for a number of years. I work with Kent Community Health in Fort Lauderdale. Our head office is based in Sarasota, Florida. I want to thank the organizers as well as the audience that have taken interest in this case. This case represents challenges that are faced by the patient as well as by the provider. Regarding the patient, tolerability issues with leading to resistance of medications with limited treatment options presents a big challenge. This was the case in my patient who was diagnosed in 2003, and because of intolerability issues, he was resistant to the NRTA class of medications as well as to the NNRTI class of medications. He was on dialysis, he had comorbid conditions of diabetes, cerebral vascular disease, he was on thrombolytics, he had lipid disorder, and had many hospitalizations because of hypertension. And when the HOPE Act was enacted in 2015, this accelerated the patient's chances to get a kidney transplant. As you know, with the HOPE Act, patients who are HIV positive can donate organs, as well as that's the same for the recipient. So luckily, this patient underwent a successful kidney transplant in 2019 and is doing extremely well as of now. However, there are a couple of learning points. One, the patient has to be undetectable pre-transplant, during transplant, and post-transplant. Pre-transplant, his regimen was darunavir, Norvir, really dosed dapagliflozin, tenofovir, dapagliflozin, and emtricitabine, and raltegravir. However, he'd be primed so that the medications that are used post-resection would not interfere with his treatment. So that left abelizumab as a viable option, and this was taken up with the kidney transplant and used, and the patient did extremely well. He's currently on abelizumab every 2 weeks. He's on dolutegravir daily, and he's also on emtricitabine as well as tenofovir alafenamide daily. His latest labs, in addition to the labs in the poster, from May of this year, 2022, indicate that he's still undetectable with a CD4 count of 26%. This case illustrates the use of abelizumab as a landmark in the treatment of these patients with limited treatment options, and in this case with the transplants also. It is a monoclonal antibody that works in a unique way as a CD4-directed post-attachment inhibitor and works at a site that does not cause immune dysfunction. My patient is taking it very well, and importantly, during the transplant period, he had to be on a temporary PEG tube for a while, and this drug was a key anchor point to take him through that period. It should be highly considered in these patients who have limited options, and based on the tolerability and lack of drug-drug interactions, I sincerely hope it can be used with success in many patients. Thank you.